Hello everyone. Thank you Hannah for the presentation and for the introduction and for all what you do for colorectal cancer screening and awareness in Lebanon. I would also like to thank Merck for sponsoring this event as well as Science Pro for organizing it. So my name is Hady Ghanem. I'm an oncologist at Lebanese American University Hospital. So today, after the excellent talk of Dr. Abi Nasser, I would like to discuss in the next 20 minutes the general treatment approaches in metastatic colorectal cancer. And this is an important topic that is gaining a lot of attention, especially during the Colorectal Awareness Month. So in the next 20 minutes, I would tackle the general overview on treatment approaches in metastatic colorectal cancer, as well as the guideline recommendations for resectable colorectal cancer, the primary tumor resection, as well as metastatic resection, general guidelines on systemic treatment in metastatic colorectal cancer, as well as targeted therapy, without forgetting the importance of palliative care in the next few slides. So the guideline recommendations for resectable metastatic colorectal cancer. So my topic will not dwell on adjuvant treatment, but on metastatic colorectal cancer. And as you know, some of these metastatic colorectal cancers are referred sometimes for immediate resection. And we have guidelines from Europe, you know, the ESMO guidelines, from the USA, the NCCN guidelines, as well as multiple other guidelines, mainly from the Pan-Asian Society. It is important to know that these guidelines actually are, for the most part, similar, but they also can have some differences, especially that these guidelines sometimes are not applicable in a very specific situation or a very specific country. So it is important at the end of the day to know that the treatment approaches in metastatic colorectal cancer should be personalized and discussed within what we call a multidisciplinary team, as all decisions have to be really taken into consideration the patient characteristics, the preferences, as well as the tumor resectability. And as we know, the options include either surgery with systemic treatment, sometimes systemic treatment followed by surgery. This is what we call neoadjuvant chemo, or what we call conversion therapy, meaning that we try to transform a non-resectable disease into a resectable or a surgical one. So it is important to optimize our first-line treatment, and this is what we always tell our patients, that we have in most of the cases, one chance to cure cancer, and that's the first one. So technically, we know that from multiple studies that have been done in the past 2 decades, that most of the patients who receive first-line treatment that you see here in the pink circle, these are patients on the first-line treatment. If you take 100% of patients receiving first-line therapy, only around half of them, or 45% of them, would receive a second-line treatment. And that number will go down to only 20% when we talk about third-line treatment. So it is very important to optimize our first-line regimens to best treat our patients. And that first-line treatment options for patients who have metastatic colorectal cancer does include chemotherapy with either anti-EGFR component or an anti-VEGF therapy and or immunotherapy that we will talk about in the next few slides. I think Dr. Abi Nasser mentioned this. The primary tumor resection is very important, especially when patients don't have metastatic disease, but sometimes, especially when they present with metastatic colorectal cancer as well as an obstruction in their colon, surgery is still warranted. And depending on the site and the location of the initial tumor, different treatment approaches as far as the surgery is concerned can be done. Either a left hemicolectomy, right hemicolectomy, sigmoidectomy, transverse colectomy, or proctectomy, depending again on the site of disease that needs to be removed. Now, following resection, it is important to understand that some patients would require what we call a colostomy, and that would be mainly because there would not be a proper resection with possible anastomosis that can be done. Sometimes that colostomy or stoma can be reversed a few months later after the patient has finished his treatment. In most of the cases, we try to do what we call an anastomosis, which is a reconnection of the remaining bowel tissue, and coloanal anastomosis is, for example, performed after a proctectomy. In most of our patients, we try to avoid colostomy due to its implication on lifestyle as well as quality of life. When do we go for resection of metastases? And this is a very controversial subject, and I will just give you some few guidelines on it. But at the end of the day, the most important aspect of this metastasectomy is basically to take every single patient into a multidisciplinary tumor board and discuss whether it can be done upfront or later on at the second stage, etc. But the take-home message from this slide is that anytime we have a metastatic colorectal cancer with only liver metastatic disease, when we can do liver resection, those patients who are able to undergo liver resection would actually behave better, and they actually live longer, and their overall survival is better than patients who are non-resected. Of course, these have to be very well and nicely selected for them to be eligible for these kind of resections, and we have to aim for an R0 resection, which will increase the likelihood of not having a cancer recurrence. So as you know, an R0 resection being a resection with a curative intent, with no detectable residual tumor, neither microscopically or macroscopically, and the worst outcome that we can get from metastasectomy is get what we call an R2 resection, which is a macroscopic residual tumor. Now, switching gears to talk about systemic treatment, because when the mainstay of a patient who has metastatic colorectal cancer is the mainstay of treatment is to use what we call systemic treatment. And as we discussed a few slides ago, the most important aspect of systemic treatment is not only chemotherapy, but also to combine it with what we call targeted treatment. And in the past, it used to be thought that chemotherapy would be replaced by targeted treatments. However, we know from all the studies that have been done in the last decade that chemotherapy is here to stay. However, we can do better by incorporating targeted treatments within the chemotherapy regimens so that the best treatment approach can be administered based on every specific patient. So the role of perioperative systemic treatment for treatment of metastatic colorectal cancer has been well solicited and has been well established, and that can be done either in an adjuvant setting, meaning administered after surgery, and this is basically the classical case of doing a colectomy and metastatic resection up front, followed by chemotherapy. However, most of the experts in the field believe that what we call a neoadjuvant approach, which is chemotherapy plus or minus targeted treatment, should be done prior to a colectomy and metastatic resection for best outcome. And this is what we call a conversion treatment, meaning we try to do a chemotherapy to try to decrease the risk of having other secondary metastases before we resect either the primary with the colectomy or undergoing a metastatic resection. Unfortunately, there is no phase 3 prospective trials to evaluate which approach is better. However, as a consensus, most of the experts would agree that neoadjuvant approach, whether all administered before surgery or as a stage resection, colectomy followed by chemo, followed by metastatic resection, should be offered for patients on a selected basis. Focusing on the chemotherapy regimens, the standard of care is to use what we call a doublet chemotherapy, and this has been established to be either a FOLFOX regimen or a FOLFIRI regimen, or the folic acid plus 5-FU could also be replaced with a capecitabine-based protocol, and those have been studied in multiple regimens and have been proven to be very similar as far as the response rates are concerned, as well as overall survival. In selected patients, a all-in treatment, or what we call the cytotoxic triplet chemotherapy, can be offered, but that's a very that has to be tailored and specifically used for well-selected patients who can tolerate the side effects of a much more aggressive regimen. And that combination is called FOLFOXIRI, which is basically a little bit of different regimen compared to the FOLFIRINOX that we use for metastatic pancreatic cancer. We have to know that these side effects are more common with FOLFIRINOX or FOLFOXIRI compared to either FOLFOX or FOLFIRI, thus limiting its use except for specific patients where we really need the best overall response rate and need shrinkage of the tumor for specific reasons, for example, prior to surgical resections. Switching gears to the targeted treatment. So as we said, chemotherapy is here to stay. However, all these targeted treatments have been proven to be very effective, and they add on overall survival benefit when they're added to chemotherapy. And they are all listed in this diagram right here, either antivascular endothelial growth factor or anti-VEGF, either bevacizumab, ramucirumab, or aflibercept. The second class of medication that can be used are anti-EGFR. The third one is the protein kinase inhibitor, and last but not least, the immune checkpoint inhibitors. As you know, there are two anti-EGFRs that can be used, either cetuximab or panitumumab, and those will be discussed. There are some few differences in between those two medications as a class. So when we're talking about the EGFR pathway, we have to understand that that pathway can be constitutionally activated, especially when the patients have the RAS, KRAS, or NRAS mutations. And when you have a constitutional activation of this pathway, the use of anti-EGFR therapy is now known to be contraindicated, and basically those patients do not derive any benefit from anti-EGFR treatment. However, for patients who are KRAS or NRAS wild type, meaning they don't harbor the mutation in the KRAS or NRAS antibody, then those patients can benefit from the anti-EGFR treatment, and the efficacy has been very well known and established for cetuximab based on 1 phase 2 and 2 phase 3 studies, and for panitumumab on 1 phase 3 studies. And we know, for example, from the OPUS, the CRYSTAL, and the TAILOR trials, that the overall survival, overall response rate, as well as the PFS benefit has been well established for the addition of cetuximab for patients who have KRAS wild type and NRAS wild type subgroup. So this is why the approval has been limited for cetuximab as well as panitumumab for patients who are KRAS, NRAS wild type. Now, looking at the side effects of these anti-EGFR targeted treatments, they're a little bit different between cetuximab and panitumumab. For example, the most common side effect is skin reaction, mainly on the face and chest, which can sometimes be problematic, as you can see from the grade 3 acneiform rash that you have on the slide. That skin reaction rate is a little lower for cetuximab. However, the acne-like skin reaction can be a little bit higher for cetuximab compared to panitumumab. The rate of discontinuation can be lower with cetuximab. However, the higher rate of infusion reaction related to cetuximab, based on the fact that it's not a fully humanized antibody as the panitumumab. So we see these infusion-related reactions that sometimes can be prohibitive and can, if severe, contraindicate the proper use of the treatment. As far as the anti-VEGF therapy is concerned, as you know, we have 3 antibodies that are well established to be effective in the treatment of metastatic colorectal cancer. One of them, the most important one, being bevacizumab, and the best studied in either first line or second line, as well as aflibercept and ramucirumab. Those exert different effects on either VEGF-A or B or PIGF based on which molecule that we're using, but the endpoint result of all 3 of them are to decrease the angiogenesis, which is involved in the pathogenesis of metastatic colorectal cancer. So all these 3 are available, and they are approved for use in the first line registration trials. For example, those 2 phase 3 studies have established bevacizumab in addition to backbone of chemotherapy to improve the progression-free survival as well as overall survival. Other 2, aflibercept and ramucirumab, are approved in second line. So those should not be done or used in first line setting, and they have only been approved in the second line setting. The third molecule that we can use, or third class of targeted treatments we can use, is called the protein kinase targeted treatment. These are small molecules, so this is different from the big antibodies that cannot that exert their effect on the extracellular level. These are small molecules that use the tyrosine kinase intracellular part to inhibit the angiogenesis. And regorafenib, which is the only medication in this class that's approved for metastatic colorectal cancer, has been based on the correct phase 3 studies, which has shown a subtle but a real improvement in overall survival. Dr. Therese also mentioned the microsatellite instability, and I think we had a question related to this during our first session. So just to keep it easier without going in depth into the pathophysiology of this, we have to understand the importance of microsatellite instability or stability of this metastatic colorectal cancer. So as you see here, MSI high status is typically associated with poor outcomes in patients who have non-metastatic colorectal cancer. However, now that we know that immunotherapy is active in patients who have MSI high, this has been associated with a better overall survival based on Keynote 177 and Checkmate 142 that have studied pembrolizumab and the combination of nivo plus ipilimumab in that MSI high or dMMR metastatic colorectal cancer setting. And both these studies have shown a difference, a significant difference in overall survival with either pembrolizumab or the combination of nivolumab plus low-dose ipilimumab, even in first-line treatment of metastatic colorectal cancer, MSI high only. And as you can see here, especially in the long-term outcomes of Keynote 177, those patients receiving pembrolizumab are able to achieve a very consistent overall survival difference, and you see the two curves are still divergent even at 5 years of follow-up. The median overall survival has not been reached in this study, which is a proof of concept of what we call the tail of the curve, the long-term duration of response for patients responding to immunotherapy. Again, these are only MSI high patients, and those who are MSS should never be treated with the current setting with immunotherapy. Last but not least, palliative care. In all patients with metastatic colorectal cancer, whether we are treating a patient in first line, second line, third line, or even just with symptomatic treatments, palliative care is a cornerstone of every single treatment of every single patient. So it should begin at diagnosis, should not be delivered concurrently with disease-directed life-prolonging treatments. However, supportive care should be part of any long-term treatment for metastatic colorectal cancer patients. That includes psychosocial, spiritual care. We should look at the patient needs. This is when we tell our patients it's the time to look at you as a patient and not on your disease. We almost forget that you have cancer and we have to treat your symptoms. We should optimize the management of the distressing symptoms. This should be done in conjunction with a multidisciplinary team, with a psychologist, with a social worker, sometimes with spiritual care, as well as hospice care. These are very important aspects of treatment, especially in metastatic colorectal cancer, where supportive care is very important. So I will end with this slide with my key learning points. For patients who do have an initially resectable metastatic colorectal cancer, patients should be referred either for immediate resection, or if they are unresectable or borderline resectable, a sandwich technique should be performed with neoadjuvant or conversion chemotherapy before referring to surgery. Treatment can be offered to patients, but these are more and more personalized based on the molecular phenotype and the tumor location. Backbone of chemotherapy plus targeted treatment should be offered to all patients, and immunotherapy for patients who do have MSI high tumors. So the other important aspects of this is the sidedness of the tumor, which Dr. Abi Nasser also alluded to. It's important to know that the right-sided RAS wild-type metastatic colorectal cancer do have a poorer prognosis, the left-sided being better. The anti-EGFR is still recommended in both, especially in many guidelines, including the ESMO guidelines, especially when cytoreduction is the goal. So with this, I'll finish my talk, and I thank you again for your attention.